Thanks, Carolyn. My name is Alwyn Johnston, and I'm co-chairing with Carolyn today. And we're moving a little bit to a different topic now. So we're going to go to Dr. Jag Gill, who most of you will all know. And Jag is Associate Professor of Medicine at the at UBC Division of Nephrology. He's also a transplant nephrologist at St. Paul's Hospital, Medical Director of Data and Quality at BC Transplant, Vice President of CORE Registry, and he's also a Michael Smith Scholar and Research Scientist at the Centre for Health Evaluation and Outcome Sciences. And he is peer review funded for many agencies, including CIHR, Kidney Foundation of Canada. So it's with great pleasure that I hand over to Jag, who's going to talk a little bit about update on donation as a continuum from David's talk this morning. So Jag, thank you. And just one quick word. Can I get people who are standing to come to the front, because there's lots of tables free in the front. Thank you.
Thanks, Owen. Good morning, everybody. I appreciate it's late in the morning and everyone's been sitting for a while, so I'll do my best to get us back on time here a little bit if I can. So as Owen said, I've been asked to give a bit of an update on organ donation, which is obviously fairly broad. And so what I'll try to do in the next half hour is outline why we care. Why is this important? And most of you appreciate this point already, but it's worth, I think, highlighting again. I'll review some trends in organ donation in British Columbia, in Canada, and also benchmark that with what organ donation looks like elsewhere. Outline, as we go through this, some of the barriers to both deceased and living donation that I think are relevant everywhere, but there are some issues that I think are specifically relevant to BC. And in that, talk about some of the mechanisms to expand both of those areas. So why is this important? Well, clearly, simply put, and I'm certainly not biased in this opinion, but is transplantation is the best treatment for our patients. I said it's an opinion. I don't think it's an opinion. I think it's a fact. And I think there's lots of data over many years now that has consistently shown us that patients who get a kidney transplant have prolonged survival, have a better quality of life. And that's been shown in increasingly what I'd say marginal subsets of patients. And so, you know, the history of transplantation is we've moved from transplanting the best of the best to not necessarily the best of the best. And the reason for that is because we have been seeing some more complications in those patients, but ultimately the data still suggests that the outcomes are still better in those patients when you benchmark them against the alternative of staying on dialysis for the rest of their lives. The other thing we have to remember is transplantation is cost saving. And so again, kidney transplantation saves the healthcare system a ton of money versus ongoing dialysis care. So clearly this is important. And as a result of this, the demand is high. So you'll see when I show you some of the numbers, our donation rates are going up, our transplant rates are going up, but the demand is far from being met. And this slide is US data, but the picture is very similar in Canada and in British Columbia, where you've got dialysis rates that have gone up and have plateaued a bit, but are still very high. And transplantation rates are not keeping pace with that. And so this divide continues to be the case. Now, this is the number of people that are listed for a solid organ transplant in Canada. This is data from CORE. And so just over 3,500 Canadians are on an active list waiting for an organ. Most of those people, about 2,700, are waiting for a kidney, followed by liver, and then pancreas, heart, and lung. Makes smaller numbers, but still sizable. Now, if we look at how people do while they're waiting on the list, what we've got in the bars here is, again, the absolute number of people waitlisted for a kidney transplant. And in the line along the bottom, you've got the proportion of people that die per year while they're on the wait list. And so percentage-wise, that looks small. It's 3%. But you're still looking, you know, at about 100 people a year that are dying while they're waiting for a kidney, which is not acceptable. And the other thing you have to remember that when we look at patients on an active wait list, especially for kidney, it's really the tip of the iceberg. We all know there's many, many more people on dialysis who haven't yet been referred or who have been referred or in workup that are still eligible for transplantation. We have to wait a long time. For our patients have to wait a long time to get a transplant. This is, again, national data broken down by blood type. And I'll just look at the first row because that's the most relevant there. And this is among adults, the average time on dialysis that is spent prior to getting a kidney transplant. And so it's the wait time, essentially. So on average, Canadians are waiting about 4 years. If you look at this by blood type, there's obviously variability. Blood type A, or if you're blood type AB, you're not waiting as long. The national average is about 3 years or so. And if you're blood type O, you're looking at about 4 years. If you're blood type B, closer to 5 years. Now, those numbers are variable by province. And if we look at British Columbia, our blood type A patients, for example, are waiting closer to 2 years now. Blood type O patients are similarly waiting about 2.5 years. Blood type AB is really quite short as well. It's the blood type B patients that are still waiting 5+ years for a kidney. So the numbers are a little better than the national average because we've had an increase in donation in this province. But generally speaking, there's still very, very long waits for our patients. This is liver transplant candidates, and I only put this slide up to remind us that when we talk about deceased organ donation, it's not, I know this is BC Kidney Days, but it's not just about kidneys, and there's people that are waiting for livers and lungs and hearts, and the vast majority of those people are only going to get one with a deceased organ donor. And I showed you the line on the mortality for kidney transplant waitlisted patients. Well, it's obviously much worse if you're waiting for a liver, and the mortality is significantly higher, with 24% of patients on the waitlist dying in 2016 while waiting for a liver. Now let's look at donation rates in Canada and then in BC and what's happened. So this is, again, national data looking at the absolute number of donors. And I've got deceased in the orange, and in green you've got living. I'll come back to living. Let's just focus on deceased for now. So 758 people donated their organs after death in Canada in 2016. And you can see certainly in the last 4 years, there's been a steady increase in the number of deceased donors after a long period of kind of stagnation on the deceased donation front. This is another way to look at it, and it's not the perfect metric, but it's a reasonable one to compare when you're looking at other countries. So this is the deceased donor rate per million population. So what this means is that for every million Canadians, how many people ended up donating their organs after death. And we had been sitting in Canada at about 14 donors per million population for a long time, and that has steadily increased, and in 2016 that number is at 21.1 donors per million population, which is quite respectable. If you look at where we sit in Canada compared to other countries, we've got Australia, Canada, Spain, the United Kingdom, and the United States outlined here. Canada's the one in red, and it's not at the top. It's clustered in the bottom along with countries such as Australia and the UK. You see Spain right at the top at a deceased donor rate that's close to 40 donors per million population. That's the largest rate nationally in the world. One thing to be cautioned, though, when we're comparing these rates is that when we're looking, the way people define donors in different countries is a bit different. So in Spain, for example, any donor that's recovered is included, whereas in Canadian rates, we're actually only taking donors where an organ was actually utilized and transplanted into somebody. So the divide might not be that great, but nonetheless, there is lots of variability between different countries. This is looking within Canada at what these rates look like by province, and it's messy, and so don't worry about looking at trying to figure out which line is which. The main point is that it's messy by design, is that there's lots of variability in the country. But most provinces have shown an increase in the last few years, so this is not isolated to BC. Now, if we look at what's happened in British Columbia, in Canada, I've showed you these numbers already, that's highlighted in blue. BC is the number in pink there, and what you see is that between 2009 and 2016, there's been a tripling in our rate of deceased donation, which has been pretty remarkable. And if we try to understand why that is, so why has deceased donation in BC in particular, which in 2009 we literally had the lowest donation rates in the country, and we've now got we're in the highest with Ontario and Quebec. And so how did that happen? Well, I think there's three major issues. One has been a concerted investment in identifying and making sure that all potential deceased donors were referred, and I'll get to some of those in a second here. The other big thing has been an increase in donation after circulatory death, and the third has been a gradual increase in the acceptance of what we'd call higher risk donors, and so these are higher infectious risk donors, older donors, and so I'll touch on each of these points now. So this is again that same slide I showed you where the increases happened. So what were the initiatives or key events in our province that led to this? So in 2009, there was a change in BCT leadership, and there was a really concerted effort to engage the critical care community. Organ donation doesn't happen without the critical care community buying into this. And leadership involved critical care, and that was with Greg Grant initially, who led BCT and really was a critical care specialist who was involved in organ donation and promoted that in his critical care community. That continues now with Dr. Keenan, who, again, we actually have a formal role in BCT as a director of organ donation, an intensivist who engages the critical care community. So this, I think, is a critical piece to kind of get that community on board. What led from that is a lot of process issues improved. So many ICUs across the province have dedicated in-house deceased donor coordinators to be there for increased education, to support the process, to support the critical care teams in identifying and consenting donors. And then the other big thing, as I said, is expansion of DCDs, which has been a new mechanism of donation in the last decade that's made a big difference and is logistically challenging. So I'll spend a couple minutes talking about DCD because I think it's significant. And DCD stands for donation after cardiac or circulatory death. And it's different from brain death. So the majority of deceased donors are, all deceased donors typically undergo significant neurological injury. What happens in the context of brain death is that that injury is severe enough that it actually constitutes a legal definition of death. You're brain dead, and then at that point you can go and you can consent for organ donation and procure organs. With donation after cardiac death, what happens is the patient also sustains a very significant neurological injury that is not compatible with a long life or with a healthy life or recovery. But they may not meet those specific definitions of brain death. And in that case, there's a decision that may have been made by the family along with the team to say they're going to withdraw care. So in that case, you can still go and now consent organs, but the patient is still alive. And so the logistics are different. And so whereas with a brain dead donor, you can go to the OR, you can procure the organs, you've got perfusion of organs all the time because you're not violating what's called the dead donor rule, which is the most intuitive rule that you can't kill people to get their organs. But with donation after cardiac death, what ends up happening is that you actually have to withdraw life support. You have to let the person pass away, have a period of time to confirm that has happened. Then you go to the OR and do that. So there's a period of time where your organs are not getting perfused very well. So that raises concerns about outcomes, and I'll come to that in a moment. But what we've seen is that has increased the pool of donors, and 20% of our deceased donors now in BC are as a result of donation after cardiac death. That's a new source of organs. If you look nationally, we're right on par with where the rest of the country is. And so really, again, this is looking at the proportion of all deceased donors that are donation after cardiac death. And across the country, it's just roughly 20%. And the major provinces that have been doing this are Ontario has done this to a large extent, Quebec and British Columbia, and all the other provinces have now come on board as well. This is looking specifically in BC. As I said, it's about 20%. And you can see that you had a rise in DCD. Now, importantly, there's also been a rise in NDD because of those initiatives that I told you earlier. So it's not just all DCD that's contributing to this. So what about the outcomes with using these? Because obviously if there's a different process, we're worried about the outcomes. And about half of the patients that get these organs, the kidney will not work immediately. It's something, they have something called delayed graft function where they may need dialysis support in the first while after they get transplanted. But if you look at long-term outcomes, the outcomes are startlingly similar to those from brain-dead donors. And this is basically, this has been shown in a number of studies. This is the most recent one that looked at this again. And the two curves you're looking there is the graft survival after transplantation among DBD, donors after brain death, versus DCD. And you can see those lines are superimposable. So long-term, they do very well. And that's been why this has been pushed as another mechanism and been expanding. The other major source that we've had is there's been an increased acceptance of older age donors. And this is something, again, that's not happened overnight. This has been going on for at least a decade where we've slowly been edged in accepting more and more older deceased donors. And this is again looking nationally at what our breakdown looks like of deceased donors by age. And so each color there represents a different age group. And the main point is that in 2016, roughly half of all deceased donors were over the age of 50, and about a quarter were over the age of 60. So certainly there's more older donors that are making up a larger pool of the deceased donors that we have. Now, if we look in British Columbia, on average, our deceased donors are actually younger than the national average. So if you, again, this is a similar breakdown that as you saw on the last slide, the bottom two ones there, the bottom green is those donors that are age 65 and older, and then the lighter green there is those are 50 and older. So in 2016, it was about 40% of our donors as opposed to half that were over the age of 50. And we had a large pool. But again, if you look at the trend over time, I said this didn't happen overnight. We've been using these organs for quite some time now, and there hasn't been a lot of change in terms of a big push, but nonetheless another important source. Now again, should we be using these organs? What are the outcomes like? And these are the questions we always have to ask. And specifically, how well do these organs work? And who should we allocate them to? Which I think is the much trickier question. So what are the outcomes like? So the short answer is not as good as if you have a kidney from a younger donor. There's no question. If you get a kidney from a younger donor, you're going to do better. Those kidneys are going to last longer. And so this is BC data, and this is crude, just looking at overall graft survival in patients depending on the age of the donor. And the clusters on the top are donors that are all under the age of 50, and the cluster on the bottom are from donors that are over the age of 50. And so, yes, the outcomes vary by age. 50 seems to be the big cut point. The couple points to remember here. One is these are unadjusted curves. So we haven't accounted for who got these kidneys. And as I'll show you in the next couple slides, generally the kidneys from the older donors are allocated to older recipients who may be more marginal, and so their outcomes may not be better to begin with. So take that with a grain of salt. The other point is I've highlighted there the 5-year survival just because that's a good standard metric to look at. So if you're looking at 5-year survival in these patients who are who get the kidneys from the over 60 and over 50-year-olds, you're looking at around a 70 to 75% graft survival at 5 years. And so that's not as good as the 85% you have from the younger donors, but again, you have to contextualize it. So what's the alternative? And the alternative is dialysis. And this is US data, so admittedly outcomes are worse in the US than in Canada, but nonetheless it highlights the point that if you look at 5-year survival of people on hemodialysis or patients on peritoneal dialysis, those numbers don't look that great. So 41% of patients are alive after 5 years on dialysis in the US, 50% of patients on PD, and if you compare that now to the 75% number we're looking at, it's a simplification, but it does give you the point that this is something that is not so bad. So we have to be considerate of what the patient's other alternatives are. So how should we allocate these organs? Well, the answer is that we need to match this as best we can. So what we do in most regions in Canada do is something called longevity matching. So what that means is we're essentially trying to match the life expectancy of the kidney to that of the patient. So we want to take a kidney that's going to last 10 years and say it would be ideal if we can allocate that to a person with a life expectancy of 10 years so that they will live out their natural life with a functioning kidney, and after that person passes away, that kidney wouldn't have been much use anyway, so it worked out perfectly. Now, in trying to design an allocation scheme around this, you have to kind of really balance two major things. On the one side, we want to be equitable. So we want to make sure that we're not disadvantaging one group by giving them the worst organs, so to speak, all the time. At the other hand, we want to maximize our utility, and that's what longevity matching really is trying to do. You're trying to maximize the utility. We want to get as many years of function out of those kidneys as we can. So if we never longevity match and we totally go down an equity-based system, then we could have this scenario where a 19-year-old donor's kidney is allocated to a 7-year-old recipient. That's great for that 7-year-old recipient, but that patient may be dead in 10 years, and when that happens, you've got lots of other kidney years that were potentially wasted and could have been used by somebody else. So that's a very, that's kind of an equity-based system. If we are very heavy on utility, we're always going to allocate that young donor kidney to the youngest potential recipient, which is great because you're matching that up. But now if you're always doing that, then that older patient will never get a chance at getting the better kidneys as well. So you have to balance it. So this is what we've come up with in British Columbia. Some variation of this happens across the country. As you know, most health policy is driven provincially, so there's not a uniform national thing. The Canadian Society of Transplantation is working at trying to come up with a national allocation system so that we can actually be much more consistent irrespective of which province you live in. But nonetheless, this is what happens. So we define a young donor as a donor who's under the age of 35. And that is allocated to a young recipient who is not defined as under 35, but is defined as under 55. And the reason for that is because the distribution of age is very different in our donors and our recipients. It's obviously, we have an older recipient pool and a younger donor pool. So if we just restricted those young donors to under 35, then you have a lot of people who are going to be waiting a long time to get a kidney. On the other extreme, we have our older donors, which is generally donors 60 or older, are allocated to our older recipients who are 60 and older. And that's a bit more equitable in terms of the distribution there. And then our middle-aged donors, which are aged 36 to 59, and by the way, is the largest group of donors we do have in BC, are allocated first come, first serve, irrespective of the age of the recipient. So that's a balance of looking at this. Now, we've had this in place since 2009 now. We're currently in the process of evaluating this and reevaluating this because our donor distribution has changed a little bit. They're getting a bit younger, and our recipient population is getting a bit older. So we need to reevaluate this and maybe have a fourth category of patients. But the premise when you're allocating these is, if we're taking an organ that is not expected to have the best outcome and we think it's going to be more marginal, well, you have to give it to a patient who's going to have a similar anticipated survival as the kidney, but also to somebody who's going to gain some additional benefit. And so things we're banting about and haven't finalized yet are issues like, well, maybe you have a kidney from a very marginal donor, and maybe rather than give it to the person at the top of the list, we should be going to the other extreme and going to somebody who has an anticipated weight that is prohibitive, and maybe they're never going to get a kidney otherwise, and this is their chance. And so in that case, it may make sense to give them those. So those are the types of refinements that I think still need to be made to make sure that we're using these organs and we're not wasting any, but at the same time, we're allocating them responsibly. It's important that even with these kidneys, although I've said the outcomes aren't as good, the survival benefit compared to transplantation persists. And this is a study we did a while ago looking at older patients. So these are patients over the age of 65. And just to explain this, what you're seeing in all those curves is the blue line there across the horizontal. That's your reference. That's people waiting on dialysis for a transplant. And all those other lines, the green, the purple, and the red, are what happens to people who get transplanted. And what we're looking at is the risk of death, the relative risk of death. So early on, there's a high risk of death. The older your donor is, that early postoperative period gets that much more complicated. But then ultimately, there's a survival benefit in all of these groups, irrespective of the type of donor they get. Now, discard's a big issue. Not so much in Canada that we appreciate, but it's probably an appreciated issue in Canada. So in the US, about 1,500 kidneys are discarded. These are kidneys that have been procured, consent's been taken, and then they get discarded because of poor quality. A lot of these could have been used because the tools that we use to define a kidney as poor quality are really not very good. And so, they're not very predictive of outcomes. There's lots of studies that have shown that the same types of kidneys are discarded, have been transplanted in others, and you had good outcomes. So that's a lot of organs that are being thrown in the garbage. And if you even thought you're going to get 5 years each, just 5 years survival off of those 1,500 kidneys, that's 7,500 years of kidney life that is being thrown away each year in the US. Now in Canada, we don't procure and discard as much, but what we do is don't procure. So that's something that we need to look at, and that's something nationally that we're looking at, and something provincially we have to look at as well to really understand how many organs are not being utilized that could. Now, where is the future going? I think the future looks pretty bright in this realm, and there's a lot of work being done right now in terms of ex vivo perfusion or organ recovery. And the organ that's furthest along with this is the lung, and this has all been actually pioneered in Toronto, which is one of the largest lung transplant programs in the world. And so what the basic premise here is that what they do is they take a lung and they put it in an ex vivo lung perfusion, and the circuit there is, I won't in the interest of time go through that circuit in detail, but essentially you've got perfusion, and you've got an ability to measure lots of quality-related issues in terms of this organ, but also the thought is that you can actually allow some recovery of the organ before you transplant it. A lot of this work is being done in kidneys as well right now. It's still in the study phase, and it's not a point where it's ready for prime time. But if we think ahead to the future, we could be in a scenario where we take an organ that's been injured as a result of the mechanism of death or whatever, and we don't ordinarily now we wouldn't use those, but you would take those, you would put them in an ex vivo perfusion machine. You would be able to test and get a better sense of how usable that organ is, and hopefully offer some therapeutics that you can actually improve that organ recovery, and do all that before you actually implant it into the patient and get a better outcome. So that's actually quite exciting, and hopefully that will come to pass in the coming years. The other big group of deceased donors are high infectious risk donors. And we've all seen on the news the fentanyl crisis in British Columbia and across the country, but particularly in British Columbia. This is updated data from the coroner service looking at the number of illicit drug overdose deaths in BC. And you can see in 2015 and particularly 2016, a huge spike, 1,000 people overdosing and dying as a result of that. Most of that is fentanyl. On the hash line, you've seen the non-fentanyl. So if you exclude fentanyl, so a lot of this has been fentanyl. So we're getting lots of calls about these organs because these are generally young individuals who don't have a lot of comorbidities or contraindications to donation. So the concern is if someone has a history of IV drug use, if someone has a history of drug overdose, should we be using those organs? And the short answer is yes, and I'll justify why. This is looking at what we're worried about. The bottom line is we're worried about the risk of HIV, the risk of hepatitis, and the transmission from the donor organs. Health Canada has a policy where there's a list of criteria. These are some of them here. If a donor meets any of these criteria, additional testing needs to be done to narrow down those risks so that you can actually assess that risk within a smaller window so that you can say, does this person have a risk for transmission? And B, we have to consent our recipient and tell them that this is from a higher risk donor, and are you willing to accept that? Now, I've just highlighted the highest risk scenario, which is an IV drug use. And this includes somebody found with a needle in their arm, so absolute IV drug use. If you do the more specific testing and the extremely sensitive testing that we have for HIV, the risk of transmission to a recipient is 1 in 4,000, which is really, really low when you think about the other risks. If we look at hepatitis C, and again, I've highlighted it there for an IV drug user, the risk of transmission is 1 in 245, which is higher, but still a pretty low number. Now, as we all know, a remarkable thing's happened in hepatitis C is that it's curable, and we've got drugs that our patients now, ESRD patients and transplant patients, can get these drugs and tolerate them well and can actually get a cure rate with hepatitis C, and that cure rate's 95%. So if we factor that in and say, now you've got that IV drug user, you've got a 1 in 245 risk of getting transmission, 95% cure rate if you treat them, if they get that, you're now 1 in 5,000 chance of actually ending up with lifelong hepatitis C that's going to have a meaningful effect. So again, a pretty small number. And this is evolving to the point where in the not too distant future, probably hep C positive donors will be transplanted into hep C negative recipients because the cure rate's so high with this. We're not there yet, but that's likely where we're headed. Now, so to summarize the deceased donation piece, we've had a more than threefold increase in deceased donation in BC. DCD and utilization of older donors have been critical to that. The higher infectious risk donors in recent year at least has been a part of that. But investment, I think, has been the big key. And investment in the day-to-day nitty-gritty processes is really what's done this. I'll end with talking about living donation and just really a couple points here. So I showed you this curve before, and I showed you that the rates of deceased donation are great. What we didn't talk about was what's happening in that orange curve in terms of the living donation numbers. And really, it's been pretty flat. And what's more concerning in the last couple of years is that those rates have dropped a little bit. Now, why do we worry about this? Because when we look at, I'll skip ahead from what we worry about this because when we look ahead at what's happening in our province in particular, we've always been leaders in living donation. If you compare our numbers to the rest of the country, British Columbia has the highest rate of living donation per million population. Some of that has been by necessity because our deceased donation rates were poor. Now, it's great that we've been able to sustain that, but if you look in the last couple of years, that's the line on the top there, we have dropped. And that's concerning. When we look at other regions in the world, this has happened. So if we look at the United States, we've seen this happening for a decade now, where living donation rates climbed, and then in the last 10 to 15 years, we've started to see a decline that's not turned around. And so that raises concern for us. Now, why do we worry about this? Because living donor transplantation is by far the best option for our patients. It's better than a deceased donor transplant. You can facilitate it before you need dialysis. You can actually get much better survival after. So it's an important thing for our patients. So what is limiting living donation in BC? Well, a big thing is medical difficulties. And so a quarter of our list, at least, is highly sensitized, which means that they match less than 5% of the donor pool. That makes it very difficult to find a living donor who's going to match you directly. Now, there's mechanisms around this. You guys have heard in this forum before about kidney pair donation and the paired exchange program, which is essentially a kidney swap program that allows us to take in compatible donor and recipient pairs and match them to other pairs and say, well, this person will donate to that person's recipient and that person's donor back to this person's recipient. And you can actually facilitate lots of transplant. And we've seen lots of success with that. But even within that system in the last couple of years, we're now starting to stagnate a bit, where we're left with a lot of people that are hard to match on that list now. And so we need to innovate more. One potential way to innovate is to add more people into the pool. It's really simple math. The more pairs you have, the more matches you're going to get. So we need to infuse more donors and more recipients into this mix. One way to do that is to ask people who don't need to go in the paired exchange program to do so anyways. So if I want to donate to my wife and we're compatible, well, I have the option to say, well, why don't we go in the paired exchange program anyways? I'll still donate, my wife still gets a kidney, but we also facilitate a bunch of other transplants among harder to transplant patients. And that's something that we're very seriously pursuing in British Columbia. We're the only province that are really going to be doing this in a meaningful way. We've surveyed all of our patients who are coming to get assessed for both donation and transplantation. And almost 80% of the transplant candidates and 65% almost of our potential living donors who knew they were compatible were willing to do this. Now, so this is, I think, an area that we're now going to formalize and start offering and figuring out a mechanism to actually make this happen. Obviously, we have to make sure there's no harm to the people that are going in this. So timing of how quickly we can do this, making sure we can still facilitate preemptive transplantation, that's all going to be critical to this piece. The other big barrier is financial, and it takes a lot of money to be a living donor right now. On average in Canada, about $5,000 to deal with the process, the testing, time off work, all that stuff. This is a paper we did a few years ago looking at the US data and really just kind of highlights how big an issue finances are. And so each of those lines represents a different income group based on how much money people make and the median household income. And they're looking at living donation rates. And so you see this big splay out. And the group at the top is the richest group. Living donation rates have been pretty steady there, and the groups on the bottom that have really tanked in living donation have been the poorest groups. So clearly finances are a part of this. Now we're lucky in BC, we have the living donor living donor reimbursement program that's facilitated through the Kidney Foundation, but it's still not neutral, it's not zero. So, you know, on average people are still spending money to donate their organs. And so whether that helps increase living donation, I'm not sure, that remains to be seen. But it's just not right that we're asking people to donate their organs and actually incur a financial cost for this. So achieving net neutrality is an absolute thing that we have to achieve. And there's lots of interesting things that we haven't even thought about. So many programs in the US, for example, the transplant program will pay for a life insurance policy for the donor, a short-term life insurance policy around the time of donation. So in the rare event that something happens, you've got some coverage there. That's something that we're not doing in Canada and something I think we really need to advance. The other big issue is geography. We've got a big province, we've got rural communities, we've got Indigenous communities that are living far away from us, and our current process mandates that people come to see us and mandates that those people are made aware of their options around donation in their communities. And that's something that we need to use the existing technology and strategies to try to reduce some of those barriers in geography. Cultural barriers are another big significant issue. This is looking at our living donors broken down by race. That big green box are Caucasians. All the other little categories are non-Caucasian groups. So this is particularly paramount in immigrant populations where it's hard to identify living donors. We know kidney disease is common in some of these communities, and we know that these patients are not getting the best care as a result because they can't identify living donors in their communities. They're waiting longer and they're getting deceased donor transplants. And that's not fair. So we need to engage these communities more, and I won't go through this in detail, but we're going through a series of initiatives to try to understand that better. But the number one issue really is probably they're not being asked. So we've surveyed our dialysis population, and less than 25% of patients on our dialysis units in the Lower Mainland, and this included Fraser as well, less than 25% are willing to discuss donation with family and friends. Now, that was a bit lower than I expected, despite the fact that we always tell people to do this, but that's a staggering number. And the thing that drives this is a lack of knowledge about the benefits of living donation transplantation, the lack of understanding of what the risks really are, or the safety of living donation. But the biggest issue is just it's awkward. People don't know where to start. They need some support in this. And so this is really where we need to step up, I think, and support our patients in asking their friends. How can we help this? Well, this is just looking at how long it takes people to get a transplant, and so get a living donor transplant. So if you look at the 2016 bar on the right there, you've got it broken down by the proportion of all living donor transplants that were done preemptively without dialysis initiation, done within the first year, done within 1 to 2 years, and done after 3 years of dialysis. And we're about 40% of our patients that get a living donor transplant get one preemptively, which is great. But there's another 40% that get it within the first 2 years of initiating dialysis. So the donors were there. We just didn't help them identify them early enough. And I'm taking culpability that it's our fault, but it's a multitude of factors. But I think that there's an opportunity there where we can make all those, convert them into preemptives. David Landsberg talked to you briefly about the Transplant First initiative, which is a joint initiative from the Renal Agency as well as BC Transplant, which is really aimed at trying to create supports in a systematic way across our province, irrespective of where you live and which kidney care clinic you go to. And so we can talk about this more. This is something we're very excited about. I think this is potentially a game changer in really increasing access to living donor transplantation in our province. It involves a change it's really a change in the shift of the way we think about options for patients that are approaching end-stage renal disease. And although we all know it and believe it, it's actually having a process that reminds us to prioritize and say, did we ask about transplant, and have we actually supported you in really exhausting every opportunity to find a living donor while we make the plan for dialysis and those options if transplantation doesn't come to fruition. It also forces us to really look at eligibility early. And so if there's questions on that, then we need to see those patients sooner, that we can answer those questions at an early stage as opposed to at the late stage. So to summarize, the demand for transplantation remains high. Deceased donor donation has increased, which I think has been a huge issue. Our wait times have halved in this province, and that is no small feat, and it's thanks to all the work that BCT has done on the donation side. Living donation, however, has stagnated. Thankfully, it's not declined too much, but it's starting to. And so I think now is the time for us to be proactive and try to prevent that from happening. Really what this is gonna take is really a lot of legwork, I think, on all of our parts to be engaged in our patient support and helping them to identify donors as we move forward. So I'll end there and take some questions.
So question from the floor.
Hi, Rob. Go ahead.
A great talk. Is there any inroads at all on highly sensitized patients in terms of technology that may be coming up?
So desensitization is something that is always there as an option. The technologies haven't improved a whole lot, Rob, in terms of actually getting new innovations to make it more successful. The challenge with desensitization is we can remove the antibodies and get the transplant done, but the long-term outcomes are still pretty poor. And so where we're heading with that is our ability to detect, the way we've defined sensitized patients has changed. So if we think 10 years ago, we were saying there's a positive cross-match. That's a very sensitized patient, and those are the initial studies on desensitizing. Now we're saying there's a donor-specific antibody, and we can quantify that antibody a little bit. So there are opportunities to say we're going to select antibodies to cross, which may not have the same impact on outcome, and so maybe we can do that more successfully. And so that is something, even in the context of the paired exchange, for example, where you could say, well, maybe you can't find a perfect match, but you can find a better match and then allow us to desensitize those patients. So that's kind of where it's going in terms of risk stratifying our patients better, but the technology itself hasn't evolved a ton, unfortunately.
So, Jag, we need to limit the questions, but there is a very yeah, we're nearly off the
I'll
page
set up a
here.
booth outside after, and
so we might just address a few of these, and,
Sure.
and then for people who've asked questions that we don't address, we just want to let you know that we're going to have a mechanism that the speaker will answer questions that are not answered, and they'll be posted on the website with the presentations in the coming weeks. So there's a couple of questions about the fentanyl crisis,
Yeah.
and one of the questions is, does fentanyl deaths actually damage the kidney? And does the donor kidney have a higher chance of being rejected by the recipient?
So the fentanyl itself doesn't cause direct harm unless systemically the patient's unwell and you've got a kidney injury related to that. And those are usually not the organs we're getting offered. So the short answer is no. There's no implication of the fentanyl itself on the ability of the kidney to work or increasing your risk of rejection. So the outcomes are expected to be pretty good. It's just the infectious risk because of the social history is the concern.
And on the same theme of the fentanyl crisis, hopefully these deaths will reduce. And the question was, do you think the transplant rates will continue to increase despite a reduction?
You know, I think we see blips in donation all the time, and it's one thing or the other. But I think, you know, the increases that we had in deceased donation in this province preceded the fentanyl crisis. So I think yes, I think we're going to continue to see an increase. In terms of absolute transplant numbers, I think certainly we are between the living donation and deceased donation part. This year in particular is where we've seen a big jump in terms of the fentanyl. Unfortunately, there's not a short end in sight for that. I hope there is, but it's something that's going to continue. But I think irrespective of that, all those process issues that have been put in place will, I think, ensure that the donation rates stay high.
And we just do one more question. So are there studies on mortality of living donors?
There are studies. So the data on outcomes of living donation has been a hot topic in recent years, and you know, ultimately the outcomes have been really quite favorable. So the risk of death is not at the time of surgery is exceedingly low, and that's well quantified. So it's three for every 10,000, 3 deaths out of 10,000, which is very, very low. Long-term outcomes have not been significantly different in terms of outcomes. The big interest has really been in the risk of end-stage renal disease, and the reality is there is a slightly increased risk in end-stage renal disease, but it's likely not directly as a result of the donation. It's really how well we can characterize that individual's risk before they donate. So as a result of that, we've become a little more hesitant with very young donors who've got a family history of issues. So if you've got a 20-year-old wanting to donate versus a 60-year-old, our ability to predict their risk of end-stage renal disease in the 60-year-old is much better than it is in the 20-year-old. So we tend to favor those older living donors at this point.
Thank you very much, Jack.
Thanks.